I was given this title of Clinical Trials Reading Between the Lines. What I thought, in terms of how I approach this session, was that probably what I shouldn't do is go through the standard systematic approach to reading a paper, which I'm sure you are all already very familiar with and, to be honest, can be a little bit dry. So what I thought instead was that I would just pick up on a few points that I think are interesting in the interpretation of clinical trials, things which perhaps are not quite as well appreciated amongst the general medical readership as they might be, and things that probably as clinical pharmacologists, as those who claim, I think with some reason, to have a slightly greater understanding of analysing evidence, particularly clinical trial evidence, is something that's really incumbent on us to be able to identify and comment on when present. To make a start, I thought I'd present to you a paper. Now, in much the way that you will have seen many journals sometimes reproduce papers from the past in a way to sort of remind us of where our evidence comes from, I'm doing that. I'm presenting to you a paper from 1980, which was a seminal study which remains instructive for our practice today. This concerned just over 1,000 patients who had angiographically proven coronary artery disease. They were randomized to two management strategies, which you'll notice I'm not telling you at the moment because I'll be interested to know your sort of knowledge of the medical literature history. The investigators set out in the way that I think you would hope and expect investigators to do what their primary endpoint would be. They selected an objective endpoint of all-cause mortality. They described prospectively how they would analyse this endpoint, which was that they would do a multivariable survival analysis over the first 5 years of follow-up. And in the way that many of us do when we're doing research, they selected some subgroups in which they would also repeat these analyses, you might say to explore the different effects in the population. You might also say to get the best value from the data that they were collected. Now, some of you may recognise this paper. Those of you perhaps if it's in your field of interest, you may recognise it. Others it may be unfamiliar to you. But as I say, it's instructive for our practice today. So these patients were randomised. The groups were generally well balanced. There was a slight difference in terms of left ventricular impairment in one group as compared to the other, but this by definition was a random effect because the patients were randomized. Nonetheless, that slight imbalance was there, which might be of importance. And in the main primary endpoint analysis, they found overall survival, that's the primary endpoint, that was similar in the two groups. But what do we do when we get a negative result in the primary endpoint? Well, we go on and have a look in the secondary endpoints and the subgroup analyses. And as I say, they had prospectively specified some subgroups based upon what they considered to be biologically and clinically relevant variables. And I think you probably wouldn't argue that in patients with ischemic heart disease, these are biologically, clinically relevant things. Number of diseased vessels, presence or absence of left ventricular impairment, and presence or absence of symptoms of congestive cardiac failure. And whilst there was no difference in the primary analysis and the population as a whole, there was quite a difference in the subgroup of patients who had triple vessel disease and left ventricular impairment. And here you can see the survival plots with clearly diverging curves, with a more favourable outcome in group 2 than group 1. And if you overlay on that and consider one of the other things that they had prospectively specified as a subgroup was those who did or did not have congestive cardiac failure symptoms. So if you took that group, they had LV impairment, triple vessel disease, but didn't yet have congestive cardiac failure symptoms. So you might envisage this is a group of patients in whom there's a window of opportunity to do something before the clinical phenotype becomes evident. In them, the 3-year survival was absolute difference of 20% between the two groups. That was statistically significant, so the p-value that we all desperately like to see, less than 0.01. It survived multivariable analysis, so independent of other variables, and it also survived correction for multiple comparisons. And the method that these investigators used to correct for multiple comparisons was the Bonferroni method, which some of you might be familiar with. So that's where you take the overall critical level of significance, your alpha or p-value, and you divide it simply by the number of analyses that you're proposing to conduct. And so it remained significant after Bonferroni correction. So they concluded, therefore, that whilst the treatment approach overall had made no difference to survival in the population as a whole, there was a clinically and statistically significant difference in a sizable minority, with a 20% absolute reduction in mortality, which I think would look quite nice on a Kate's plot, probably. So my question to you is, partly as a sort of test of your medical trivia test, what is the therapy that they were studying in this trial, and what's your feeling about the analysis? So perhaps I could ask you to suggest any idea what we might be. What was the intervention? That's right. That's what I was looking at. PCI, I'm having suggested. 1980. I think it was probably thrombolysis, perhaps getting more towards the era. Any other thoughts? Aspirin. Yeah, all good thoughts. And so taking that is one of our sort of standards of care at the moment, what do you think about the basis for that evidence that we're relying on? Is there anything worrying about what I've presented to you? So post hoc, well, actually, it wasn't really post hoc. They had actually pre-specified much of this. Okay, well, I'll reveal to you, actually, there was no treatment in this trial. It was indeed a real paper published in Circulation in 1980. It involved real patients with real data who were really randomized. They were really analyzed, and the analysis was real, but the patients received no treatment. And this was to provide lessons on the dangers of multiplicity in medical research. And multiplicity, I think, is something that we, as those who contribute to the evidence base and read the evidence base, need to have really at the forefront of our minds all the time. This is a slightly idealistic representation of the problem of multiplicity. Idealistic in the sense that I'm taking here what you might assume to be independent statistical tests. So if we're going to rely on the p-value, as we always do, let's assume that these statistical tests are all independent. Now, if you have one statistical test and you set the critical significance level at the same level as we usually do, so 0.05, then the chance that that test will return a negative result if there is no difference, no true difference, so if we're in the assumption that the null hypothesis is true, the chance that that test will correctly return a negative result is 0.95. And the chance that it will erroneously give us a positive result is 0.05. If you were to have two tests, so you perform two independent statistical tests, then the chances of both of them correctly giving a negative result is 0.95 times 0.95, which comes down to about 0.9. So now you're up to about a 10% risk that you could erroneously get a positive result in the absence of a real difference. And of course, that risk accumulates progressively as you increase the number of statistical tests. And if you wanted to keep in mind an anchor number, 13, I think, is a good one, lucky number of 13, I've caused it here, because this is the point at which you tip over from being less than to more likely than not to find at least one difference just by chance. So as you go beyond 13 independent tests, you become more likely than not to find positive results by chance alone. And I think you could easily envisage how, if you just have a number of subgroups and a number of secondary endpoints, you analyze all those secondary endpoints and all of those subgroups, you can very easily get to the point that you have more than 13 tests. So I think this statement here that multiplicity threatens the validity of every statistical conclusion is a bit dramatic, but actually it's not without some basis when you consider all of the potential sources of multiplicity. So there is what you can see in the paper, the things that the investigators actually report in terms of the number of endpoints and the number of subgroups. There is also the things that you might not be able to see. So for the individual investigator with their data set, we've all been there, haven't we, where we've got our data set and we've got SPSS or Excel, and with the very best of intentions, because we're inquisitive scientists, we have a look at it. And we could all probably get through hundreds of statistical tests in an hour, couldn't we? And of course, you then pick out some positive results, which somehow falls into a narrative for you. And you can then start to build that narrative in a way that then creates a paper. It's not done without, it's not badly intentioned, but it is symptomatic of the problem of multiplicity and how chance findings can start to come into play. The other thing, of course, to consider is that the evidence base that we can see, the published literature, is only a fraction of all of the literature that is out there. And that there will be many other studies that were not reported that were negative, and so we may be multiplying the analyses in that way in such a way that the published literature is, of course, a biased sample of what is actually being done. Just to provide a little bit of evidential basis for that slightly dramatic conclusion, here is a study performed not in medical science but in psychological sciences, where in this very good article, which I thoroughly recommend, published in Science in 2015, a collaboration of psychology scientists took all of the studies published in 3 major psychological journals in a particular year, 2008, didn't apply particular selection criteria. They had a slightly sort of quasi-random selection criteria, but you could probably draw some criticisms of their selection criteria. But nonetheless, a reasonably random sample of those studies that were published. They went to great efforts to replicate them. They literally went back and did them again. They outsourced it to lots of groups and used original materials wherever possible. They powered the studies appropriately as best they possibly could, and they replicated them. This, on the right-hand side, these are the p-values in the original reported studies. These are the p-values in the studies when they were replicated. So here, less than 0.05. You can see we go from practically all of them having significant p-values to the majority of them having non-significant p-values. And likewise, effects, almost all the studies, in fact, basically all the studies, reporting positive effects in the original studies, and in the replication studies, the effect size was less, and in some cases had gone in the opposite direction. I think it's not unreasonable that a similar result might be obtained if we were to do this in the medical literature. So this is the first sort of interesting point in analysing clinical trials that I wanted to introduce to you, which was the issue of multiplicity. The second one that I wanted to discuss, which is where we have some overlap with the last session, but I think hopefully complementary overlap, is in the issue of heterogeneity. And I would suggest to you that in the classic way that medical research is reported, there is a tacit assumption of homogeneity. And by that, what I mean is, if you consider the therapeutic effects, when we have a clinical trial, invariably, the effect of that therapy is summarized as a summary statistic. And we tend to hang slightly on those summary statistics, whether it is the mean difference between groups, the relative risk of some endpoint between groups. So there is, just in presenting a summary statistic, I would suggest that there is a tacit assumption that there is homogeneity, that relative risk is evenly distributed among the trial participants. Now, of course, you're a clinical pharmacology audience, intelligent extra layer of understanding, and you would say, well, of course, that's partly true, but of course, it's not just a single summary statistic that's presented. We also have a confidence interval and standard deviation as a measure of spread, don't we? So yes, it's true. We do have something to estimate the precision of the summary statistic in the form of the confidence interval. And we also have something to try to capture the spread of effects within the population. So perhaps we understand that it's not quite as homogeneous as the summary statistic would suggest. But I would suggest even us, with our slightly higher extra layer of insight into this, still tend to fall foul of the second homogeneity assumption, which is that the spread of treatment effects in the trial is representative of the spread of treatment effects in the population from which it's drawn. And to kind of try to describe that to you, let me consider here a population. So let's imagine we've got some therapy in which we're measuring its effect in the whole population, all of the potential patients who could be exposed to this therapy. And the absence of effect is, in this case, 0. So it's maybe looking at a mean difference, for example. So there are some patients around that point of 0 where you could say there is a sort of region of indifference where there's no difference between having the treatment or not having the treatment. If we were to want to sample from that population in a completely unbiased way, then ideally what we would do is we would take an entirely random selection from the population of all the patients who could get this treatment. And so our sample population would look something like this, same shape, same spread. And we would in that way get an unbiased estimate of the summary statistic, the average effect in the hypothetical average patient, and also some understanding of the spread of effect in the population. Of course, the reality is that in studies, clinical trials and other research studies, non-interventional studies, rarely do we completely randomly select from the population who are going to get the intervention in future, because we apply some selection criteria, or even if we had very broad selection criteria, some artifact of the way that we sample, whether it's from the place that we sample, that we're only in a certain region or certain hospital, or only sampling at certain times of the day, we in some way narrow it. So in fact, what we often end up with is a sample that looks something like that. And this would be probably a reasonably nice sample if we could get it, because at least it's relatively unbiased in terms of where it sits in relation to the mean effect in the population. So this is what you might call a center-biased sample. So here we get a relatively unbiased estimate of mean effect in the population. But crucially, what I hope you can see from this is that we massively underestimate the spread of effect that would then become evident in the population. So although you might have a standard deviation in that sample, that doesn't reflect the spread of effect in the populations from which it was drawn. And of course, further in reality, the population that we sample will often not be in the center. It will be a tail-biased sample in some way, because, for example, maybe we want to select patients with more severe disease where we will better demonstrate the efficacy of our treatment. So now we have not only a biased estimate of spread, but we also have a biased estimate of the mean effect. Now, this is really important because when you consider the effect of the treatment in terms of the beneficial effects of a treatment, usually in some way relates to the severity of the underlying disease. Harm from the treatment generally, I know I'm generalizing here, but generally is less related to the severity of the underlying disease. It tends to be distributed somewhat more randomly. So probably the best way to think of this is imagine, say, surgery for abdominal aortic aneurysm. If you have a negligibly sized aneurysm, then your potential benefit from undergoing surgery or endovascular treatment or whatever we're doing these days for your abdominal aortic aneurysm is similarly negligible. But your risk of harm is much the same as if you had a 7 or 8 centimeter aneurysm where you have much greater potential for benefit. So if you understand that different distribution of harm and benefit, you can then consider how do you sample from the population in a way that may modulate the results that you get from the trial. Because there will be patients who, in this example, have net harm from the treatment, other patients who have net benefit from the treatment. If we were to sample in such a way as to preferentially get in our study patients with more severe disease, nothing wrong with this, just have to understand the implications of it. If we were to sample patients with more severe disease, we are more likely to get a positive result, whereas if we bias ourselves to patients with less severe disease, something that sort of rings true in my own research experience, you might predispose yourself to having a negative result, which I think is important both in the way we design studies and also in the way we interpret them. And here this is playing out in practice. So here in the treatment of carotid stenosis, with the outcome being a composite of any stroke or operative death. And you can see on the left-hand panel, we've got patients who have surgical treatment, have adverse outcomes relative to the patients who get medical treatment. And in here, it is reversed, where the medical treatment is clearly leading to worse outcomes than surgical treatments. And to ask the obvious question, what is the difference between these groups? Sorry? Absolutely right, yes, severity of carotid stenosis. So if you have a minimal degree of carotid stenosis, then you are exposed to all the risks of the treatment, the surgical treatment, without potential for much benefit, whereas the other way around, of course, the benefits of treatment of surgery become much more important. So what's the implications of this? Now, I think the first thing to think about, so this is sort of more my perspective from the point of view of someone who has been involved in clinical trials rather than systematic reviews, and that's to think of the heterogeneity of treatment effects within the trial sample. Now, in the first section, I was slightly bemoaning the problems of subgroup analyses and the risk of multiplicity that it generates. However, there is reason to having subgroups, and this is probably the main reason to having subgroups, which is to try and tackle that issue of heterogeneity of treatment effect within the trial population. So this is why we look at the subgroups, is to try and dissect out, is there a heterogeneity of effect? So here, for example, just a completely random example, it so happens to be a non-inferiority trial of low dose versus standard dose alteplase in stroke, and we look at, say, baseline systolic blood pressure, and you can see that there is a significant difference in favour of standard dose alteplase in patients who have a higher baseline blood pressure. So this would tend to suggest some heterogeneity. But crucially, what I would urge you to look at instead is this p-value for interaction. So what we should not be concentrating on in general is the line-by-line tests of the null hypothesis in different subgroups. So you could quite easily imagine how you could use some variable excuse me, to pick out a relatively small subgroup within a trial, test the null hypothesis in that relatively small group, and find a significant result. And in so doing, we are ignoring all of the data from the much larger group of patients who weren't in that subgroup. The crucial thing about that column that you should see on a well-reported trial with subgroup analyses is the crucial thing about that p-value for interaction is that it asks a different question. It asks the question, is the odds ratio in this group significantly different to the odds ratio in this group? So it's by that way making use of all the available data, and you can see has a less convincing probability that this is not a chance effect. So when looking for heterogeneity within an individual paper, look for that column of the test for interaction rather than the line-by-line relative risk confidence intervals and p-values. What I think is much more difficult, or what you really can't easily quantify from an individual trial report, is the estimate of the population parameters. So you need just to understand that the way in which the population was sampled could lead to bias in your estimate of the population treatment effect, and also, crucially, bias and likely severe underestimation of the spread of effects within the actual population of patients who are going to be exposed to the treatment. Okay, so that was the second thing that I wanted to talk to you about in this slightly random, arbitrary tour of interesting things in clinical trials. This is the third interesting random thing that I want to talk about. New agent to treat migraine. Now, many of you will be familiar with this because it was even on the Today program, I think, a couple of weeks ago. What's this new treatment that's now going to revolutionize our treatment of migraine? Excellent, very good. I don't even know what it is. In fact, it was a placebo, because what I presented to you here was the behaviour of the placebo group as opposed to the active treatment group of this drug that I can't pronounce, which no doubt is the class of agent that you just mentioned to me. So this is to just illustrate the issue of placebo effects. That's the third thing I want to talk to you about, placebo effects. And I have deliberately put placebo here in inverted commas for reasons that will become clear. I also deliberately chose the example of a trial in a neurological disease because this is the area in which you tend to see placebo effects most prominently, more so than you do in other conditions. And placebo effects, by definition, are expectation effects. Placebo effects is just one component of what you might consider to be sort of the unintended, non-experimental effects of experiments. The bit of it that isn't related to expectation are these things called Hawthorne effects. Does anyone know what a Hawthorne effect is? Yes, so merely the process of observing leads to a change in the observation, the observed variable, which came from some study done in the Hawthorne factory. I can't remember what they were making. It was somewhere in the US back in the 1930s or 40s, where they studied the effects of low levels of light and high levels of light and discovered that when you both decreased light levels, productivity went up, and when you increased light levels, productivity went up, and they eventually came to the conclusion that it was nothing to do with light levels, but rather the fact that they were observing productivity that changed productivity. So this is something that does fall into what we tend to group under this term placebo effects, but actually isn't a placebo effect because technically a placebo effect is an expectation effect, whereas this is an effect of being observed. Now, the other expectation effect is the opposite. So a placebo effect is the favorable expectation effect. Nocebo effect, as I'm sure you know, is the unfavorable or adverse expectation effect. Now, I think one interesting thing for us to understand as clinical pharmacologists when we're reviewing the evidence base is that the expectation effects genuinely do depend on expectation. So if your expectations change, so do the placebo effects, and therefore, by implication, as does the difference between the active and placebo groups. So again, I'm concentrating on trials in neurological diseases because that's where this is most pronounced. This happens to be an aggregate of studies in neuropathic pain. And each dot on this is a trial reported sometime between 1990 and 2014 of a placebo-controlled study in neuropathic pain. And the top left here is indicating the baseline severity of pain. So what you can see from this is that there is variability. The trials are recruiting patients with variable severity of neuropathic pain, but in general, the trend has been flat. So they haven't tended to recruit patients with more or less severe forms of neuropathic pain. Down here on the bottom left, we have the effect of the active drug. So again, a lot of variability here, but crucially over the years, there's been no systematic change in general in the response to the active drug, whatever that active drug might be. Whereas in the placebo group, the response to placebo has progressively become greater over the period of this study, so over this 25-year period or so. So what you might imagine from this is that at the beginning, when there were few proven treatments for neuropathic pain, patients had low expectations. And so when enrolled into a trial, the effect of the placebo was minimal. As the years went on and experience built with the potential beneficial effects of anti-neuropathic pain drugs, so patients, when they were enrolled into a study, started to have greater expectation that they were going to derive benefit, and therefore were perhaps pre-programmed to have a greater placebo response. The implication of this, of course, to great concern for drug companies, is that the treatment advantage, so the difference between the drug response and the placebo response, has become progressively less over the years. So it's becoming more and more difficult to demonstrate benefit with a new agent because the placebo effect has become so pronounced. And just to show that that also applies in the nocebo effect, here is an aggregate of studies testing either a disease-modifying therapy or a symptomatic treatment against placebo in patients with multiple sclerosis. And what I've brought out here is the estimate of adverse event rate in the placebo groups only. So this is not being exposed to an active treatment. This is in the placebo groups. if you were given a placebo in the context of being in a trial of a disease-modifying therapy, so perhaps a more dangerous drug in some way, you had a much higher adverse event rate than if you were in a trial where they were only testing perhaps a less noxious symptomatic therapy. So the patients, again, were pre-programmed, or maybe the investigators were pre-programmed to find a higher adverse event rate if the active comparator was, in a broad sense, more dangerous. So this was in CNS trials. Here's a different trial. This is a respiratory trial. So this is tiotropium in poorly controlled asthma. And here, I think, well, you might say in regards to the asthma control questionnaire, so some measure of health-related quality of life in patients with asthma, you might kind of conceive that this could be an expectation effect of being involved in the trial. I think it becomes more difficult to be persuaded that your FEV1 can be changed quite so significantly by placebo. It really would tend to suggest that actually we should just give everybody clinical trial type treatment and then they'd all do better. I would suggest, however, that this is an entirely statistical phenomenon related to a thing called regression to the mean, which I would suggest that we should all know about and understand. Now, to identify regression to the mean, which I'll explain to you in a minute, the crucial thing is to see look at how were the patients selected. And in this case, patients were selected specifically for their score on the asthma control questionnaire to indicate they had sufficiently bad asthma. And secondly, of course, they had to have spirometrically proven airflow obstruction. So again, the FEV1 came into the selection process to get people into the trial. Now, this is really important because when you consider, let's imagine that we've got some score that we're measuring, some control score of asthma or something. In this case, we're going to select patients with a lower score. Now, we measure, we have a population that we're sampling from, and we measure the baseline score in all of those patients, and we come up with some distribution curve with frequency of scores plotted against the score levels. What you have to understand about this distribution curve is that it is made up of the individual point measurements of all of the patients that you measured. And each patient that you measured had their own little distribution curve for their own scores, which might be because of biological variability in their disease, or it might be because of measurement error. But there is some error for the individual patient. And it could be that on one particular day, this patient, who should by rights have a score here, for some reason had a bad day and had a lower score at the extreme end of their own personal distribution curve. If we were to then apply a cutoff level, where we're going to select, say, everybody with a score below that level, then it could be that this particular patient on that particular day has an extreme score that allows them to get into the cutoff range and therefore be recruited to our trial. And crucially, the cutoff range is not placed in the center. There's not symmetry either side of the cutoff range. There is more patients on this side than there are on this side, which means that there are more patients whose own personal distribution curves happen to pop into the range that could lead them to be recruited into the trial, who by rights should have a higher score, than there are patients who by rights should have a lower score, but might on a good day have a score that leads them to be above the threshold range. So this patient, when we remeasure this patient's result, this patient's score, the likelihood is, more likely than not, their score when we remeasure it will be higher. It will go to their own personal mean. So individually, they will regress to their own mean. Also, though, collectively, all of those patients around the cutoff level will regress to their own personal mean. And remember what I was saying, there are more patients on this side who might, because, by virtue of having a bad day, have got into the trial when by rights they shouldn't have, than on this side who, by virtue of having a good day, managed to get out of the study. So what that means is that the mean that we measure in the group that we've recruited will regress towards the population mean. And this, I think, is an absolutely crucial thing for us to understand when interpreting evidence. And I would therefore put this into this group of placebo effects, but we need to understand that it's not strictly a placebo phenomenon, because strictly speaking, placebo effects are expectation effects. This is a purely statistical effect, but a very powerful statistical effect. You identify it, as I say, by looking at the way in which the patients were selected. And crucially, regression to the mean will occur whenever a population is sampled in a way that's asymmetrical. In other words, you don't take people about the mean. You take patients with a above or below some threshold level. When you measure whatever it is you're measuring more than once, and when that measurement is subjected to some random error, because that random error will lead to the patients regressing towards their personal mean. You handle it in the best way by having a placebo group, which doesn't even need to be a blinded placebo group, but the best way to handle it is by having a placebo group, but it is not a placebo effect. Okay, so I think I've used up my time. As I say, it's a bit of a random hodgepodge of things that I find interesting in the study of clinical trials. But to summarize, they are the issues of multiplicity, which we need to be so concerned with being an all-pervasive problem in the medical literature. Secondly, we should really have that appreciation of heterogeneity of effect. Understand that the effect that the summary statistic only is an estimate of the spread of effects within the trial sample, and that the spread of effects within the trial sample is probably an underrepresentation of the spread of effects within the population. And thirdly, understand that placebo effects is a much broader phenomenon than just placebo effects, and in particular includes this very powerful statistical effect of regression to the mean. Thank you.